Hi, good morning, everyone. I hope you're all doing well. I know I'm sure that not everybody's quite here yet, but I'm going to go ahead and get started with the webinar. And I'd like to say that what I'll do is because I have quite a few slides to get through today. So what I'll do is I'll have everybody just kind of put their questions in the chat. And once we finish the webinar, we can go back and answer questions that you might have and any concerns, and we can just have an open dialogue that way, okay? But yes, again, welcome to my webinar. This is Who Gets Treated, or excuse me, Who Gets Seen and Who Gets Treated, talking about accuracy and accountability in dermatology. And of course, I'm Barry. I'm a biologic coordinator and medical assistant. So before we get started, one of the biggest things that I want to talk about was our BCoD conference that's going to be happening in November. I'm so excited. It's on a weekend, which is fantastic. It's going to be at the Omni Hotel in Florida, the new one. And I really encourage everyone to, if you can and you have the time, to really go to this conference. Last year was my first time, and it was a really big source of networking for me. Not only in just all the amazing BCs that I got to meet, but it's opened up so many doors for me to be able to participate in different podcasts um, and just gained just so much knowledge that I didn't have prior to starting. So definitely look at this information here. All of this information is also on our website. So please feel free to check all of that out, please. And if anybody's interested in speaking, please sign up. The last conference was also my first time to ever speak at a conference ever. And again, like I said before, that opened up so many doors for me. And I'm so thankful for BCoD to be able to give me a platform to be able to talk about the things I love, which is what we're going to get into today. So please check all of this information out, and we'll get started. So the biggest thing when it comes to access and accountability, especially within dermatology and certain chronic conditions that I like to mention for myself personally, this matters to me, obviously being a BC, but also I'm going to be a future provider. So this kind of, when I got into the space of doing these webinars and doing these presentations, I always have that mindset in mind of how can I help the patient? How can I gain more knowledge and really dig deep into these certain topics? And so this conversation really does matter, and that accuracy does determine the outcomes. Evidence does shape the access, and representation shapes the evidence. And so when we talk about that, let's start with kind of like the accuracy determining the outcomes. And that's kind of when we kind of misrecognize disease or misunderstand severity, the treatment timelines of that does tend to shift. And a lot of that we know has to do with insurance, but the escalation gets delayed and then the patients continue to live longer with the inflammation. And then that matters in dermatology because those small delays kind of compound over time. Um, and that evidence shapes access in that, the data that we generate in trials doesn't just live in those journals. That becomes insurance criteria, which I think is the biggest thing that I learned when I started this journey was that, wow, a lot of these things that I'm reading in clinical trials, I'm also seeing that are a part of the insurance criteria. So maybe there's something to digging deeper in these trials to be able to see how I can translate that into the prior authorization process. Um, so it really does become kind of the framework for what's medically necessary. And that representation also does shape that evidence in that, if certain populations are underrepresented or underanalyzed, the kind of average patient becomes kind of skewed, and that affects how confidently that, we as BCs can escalate that care. So kind of using HS as a case study, I really wanted to highlight especially the disproportionate prevalence in Black patients, the earlier onset in many women of color, and then later specialty access. So what I mean by that is, large data US sets show that HS affects Black patients at roughly 2 to 3 times the rate seen in white patients. So when that prevalence is higher and that research isn't really proportional, then the evidence base is really just kind of incomplete from the start. So And as we know with HS, earlier onset is definitely critical. So the symptoms begin younger, but then specialty care happens later, but then that disease kind of accumulates. And so how does that look, when it comes to practice or when, patients are coming into derm, they're getting more scarring, more sinus tracts, more advanced inflammatory involvement. And then by the time someone reaches a dermatologist, they're just full blown pain, which, we'll get into later in the discussion. But I think that that later kind of specialty access is not really just a statistic, but it's also just years of the untreated disease. So, how that influence works in dermatology, this is this is probably one of my favorite slides because that influence is cumulative and the change occurs across multiple domains and the structural shifts precede data. So, influence in medicine doesn't just mean like publishing trials, it includes like the referral patterns, the CME content, coding language, who's centered in these case discussions. And it also includes how the diseases are framed. So, like how clinicians are trained and how referrals happen. So, as we continue to get this access expanded, and when the disease gets reframed, when the education evolves, that's when research begins to catch up. I think, like I was saying before, a lot of these patients, especially Black patients, because they're the higher statistic, but yet they're the least studied, it doesn't really match what we're seeing in clinical trials. And it doesn't really give us much to be able to do and resolve to be able to help the patients. So like, and what we consider normal and how comfortable we feel escalating the therapy, I think that's going to be one of the biggest keys to take away. And I wanted to take this time to kind of expound you guys on who Theodore Lawless is. Um, he's a dermatologist who had a lot, he's a Black dermatologist, excuse me, I forgot to give that key point, who really expounded and did a lot in ways of research and dermatology care for Black patients, especially in research and in the medical field. He really opened things up. He expanded that specialty care, strengthened dermatology within Black institutions, and really broadened clinical exposure. And when I first started, doing research and learning about clinical trials, he was actually the first person that I was able to actually learn about. And this definitely pushed me into this segue of where I am today. And his quote, "I'm simply trying to repay a debt of gratitude," is exactly how I feel and have felt in my lane of dermatology because it's something that I've been doing for a long time, but having someone whose sole purpose is simply just to kind of continue to open doors and push those boundaries to get access for Black patients is something that I just find incredible. And it's really pushed me so far. And so people like him, it's the reason why more clinicians are trained to recognize disease across diverse skin tones. And I think that it's really important that we take the information that he's been able to instill in me and us and help kind of propel that to the next place. So now let's talk about the diagnostic blind spot, which is, the medical education centered on lighter skin. The inflammation presents differently in pigment-rich skin, and delayed recognition worsens the outcomes. And so obviously we know when it comes to medical texts, information, providers when they're in school, you know, the things that they see in these books is basically all patients with lighter skin tones. So for decades, you know, this information for them has created kind of blind spots essentially, like the erythema, the inflammation, the pigment change. It all presents differently in dark skin. And I think when I did my presentation in at the BCoD after the conference, that was probably the question that people came up to me the most, was saying that they weren't medically knowledgeable on how these things present differently in skin. So what can we do? How can we address this? And I think the bigger thing is just earlier diagnosis, shorter time to escalation, less cumulative damage, because the quicker that we can get these patients seen, the quicker that we can assess them, it's going to be easier to be able to treat them and also help with all these blind spots that we do have. And so from minimization to recognize inflammatory disease. So historically minimized in clinical language, disproportionate burden in Black patients, and inflammatory recognition change escalation. So I think HS historically, it's kind of been described as like recurrent boils, follicular infections, or hygiene related. But I think it's important to admit or to say that when a disease disproportionately affects Black patients and is simultaneously minimized, the stigma does compound the delay. I was talking to another BC just yesterday, and her and I were talking about a patient with keloids and scarring, and how long the further that treatment gets delayed, the more that inflammation matters. And I'll definitely go into this a little bit more into a different slide, but it really is about how that perception does shape the urgency. Because if a disease, affecting Black communities is framed as behavioral or superficial, then really getting that kind of urgency or that escalation does tend to become slower. And again, kind of going back to the epidemiology of the situation, which is, the large data sets do show that this does, Black patients carry a significantly higher HS burden. Um, so I think it's important that, the recognition of HS as a chronic inflammatory condition changes that. So, what does that look like, whenever we're, dealing with this in practice with our patients? Um, it's a justified systemic therapy, it justifies biologic trials, and it justifies aggressive escalation. And when the escalation becomes legitimate, then the access really does improve for our patients. So pain and scarring and what the trials miss. So this is a really key one for me because I've noticed in a lot of the practices that I've been in that the pain is under prioritized. Of course, the hyperpigmentation persists, and then the lesion counts dominate the endpoints or what insurances expect. So I definitely want to go into the pain. So a lot of the practices that I've worked at, when I'm seeing a lot of the chart notes and I'm seeing the things that they put in, pain is never something that's stated outright. It's always kind of like we go into the Hurley stages and the lesion counts, but we're not putting in these chart notes the pain that this is causing these patients. And I think that is such a good thing to put. I know we put things like, affecting quality of life, but I think using that keyword of pain is definitely crucial when you're doing your prior authorizations as a BC. It's one of the most disabling features of HS. Um, because I know that we do, like I said, we do count what we measure, but in darker skin tones too, I kind of want to segue into the hyperpigmentation. These are more visible in people of color, which does tend to happen because of the melanin activity, but that also gives a different sense of a quality of life when your pigmentation looks differently on darker skin. It's definitely more visible. With lighter skin, you tend to get post-inflammatory erythema, which is a lot of that redness. But we get a lot of people with a darker skin tone tend to get a lot of those darker hues. It's much more difficult to treat than post-inflammatory erythema. So even when the nodules resolve and the inflammation decreases, visible pigment, that alteration, that scarring can remain. So the patient may be considered improved by, like a trial standard metric, but they still experience significant cosmetic and psychosocial burdens. And I think that that's really something that we have to pay attention to, especially someone myself who has been there when it comes to post-inflammatory hyperpigmentation. It really can affect how you see yourself, how you think others see you. So, I just want to make sure that that's something that's known. And I want to say this isn't really about comparing suffering at all. It's just about recognizing that the disease can present differently, so that the endpoint should be considered different. So, especially if you see a lot of patients in your clinic who patients of color, making sure that those things are there in the chart notes, whether you see a lot of patients of color or not, I think just having the information is 100% valuable so that you can help to treat your patients. So the intersectionality gap. I think that the biggest thing that a lot of people didn't know is that race and sex are analyzed separately, that Black women are underanalyzed, and that the highest burden has the limited intersectional data. So Black women sit at the intersection of the highest prevalence and the highest burden of HS. And again, this is new to a lot of people. So when that intersectional analysis is absent, the most affected group becomes the most statistically blurred. I've done multiple talks for different pharmaceutical companies. And afterwards, when we're sitting and kind of chatting about things and we start talking about HS, especially there's been multiple ones where I've had Black women in the room and I've mentioned HS, and a lot of them have piped up and said, I actually have HS. I have the hardest time getting treated. I'm being told that it's things that it's not. So I think, again, it's one of those real life ways that I get to really see how much this affects these patients. And when we have that kind of uncertainty, the gaps in evidence, it's definitely apparent there. So with the diagnosis, it's recognizing the presentation differences, documenting the severity clearly. And again, I put this in here for a second time, but name pain explicitly because that really does make a difference. Um, because that documentation is what shapes everything when it comes to getting these patients approved, as we all know, being BCs. So if the language is vague in these chart notes, it's going to be harder to justify. And don't be afraid of mentioning that the patient is a skin of color. I know in some EHR systems, it does have in there, you can put type 2, type 3, type 4 skin. But I like to put that in there and then I state outright in these chart notes. And that's across all skin tones. So that's, even our type 3s, our type 4s. I mentioned that these patients are skin of color because even in patients with type 3 skin, it can still hyperpigment the same way, where you're getting more of that darker versus the actual erythema. So, and then the last thing with this as well is naming pain explicitly ensures that it's acknowledged in treatment decisions. I can't say that enough where I've had multiple prior authorizations with just that small change has definitely gotten me approval over a denial. Okay. So again, kind of talking about the documentation and the shaping access, trial endpoints, insurance criteria, severity language does drive approval, and documentation does become evidence. I know that I feel like I kind of said these things on there, but I think it's also important to note that, these insurers, like I was kind of saying in the beginning, they mirror the trial endpoints. So when you're looking at a trial, researching a clinical trial, which if any of you have questions about that at the end, I'll be more than happy to answer them. The insurers, when they're doing, the questionnaires for the prior authorizations that we do, they're looking at what the trial endpoints are showing, and that's how they mirror these prior authorization questions. And I think that's the biggest takeaway that I've been able to get from doing researching trials and kind of correlating them into how I do my prior authorizations is learning. That's what they're looking for. So again, when you're researching and you're looking at these trials, you're not seeing a lot of things about the pain. You're seeing a lot of things about the lesions. You're seeing a lot of things about the live disease, but you're not really seeing too much about those specific things. So in prior authorizations and appeals, that documentation really does become your evidence to be able to help you get these medications approved for patients. All right, and so we're going to talk about escalation and accountability. So framing determines the urgency, accuracy protects the patients, and accountability strengthens dermatology. So framing HS as inflammatory does change the urgency, and that accuracy protects the patients from delayed escalation. It strengthens in dermatology because it ensures that the evidence reflects the reality and an outcome in fewer years lost control to disease. And this goes back into what I was saying before about making sure that patients are able to be seen at the initial parts of their treatment or the initial parts of their diagnosis once they do get diagnosed. Being able to treat them earlier does help a lot of these things, gets things accountable, and it helps the chart notes. So what do we do with this access? So the access is really the influence, the precision is responsibility, and the outcomes are not accidental. I actually came up with this quote yesterday as I was kind of refinishing my notes and really thinking about everything that I've been doing. I wanted to explicitly state out that the work of those before us open the doors. What we do with that access, how carefully we practice, how clearly we document, how boldly we escalate determines whether these outcomes change. Because the access with dermatology, it's not neutral. The access to the research, to the treatment, to these pathways, who's shaped, who gets seen, who gets treated. This precision really does matter because, again, the documentation does drive the approval and the language really does drive the urgency. And the access determines who receives this care quickly. So I think it's important when we're doing research for our prior authorizations, that we're, document the severity, like I said, and not just completing notes. I think that that's really important in how we do things. And so I just want to close with, we don't control every system, but we do control how to practice within them. And I think that that's where the change really begins for us and also for our patients. So I hope that you were able to get something out of my webinar today. And before I finish up, I just wanted to mention the upcoming webinars that we have coming up. We do have the next level skills, the check-in series you can see. I will be doing this same webinar again in March. I believe it's March 18th. Don't quote me on that, but if you go to the website /
March,
events, then it will let
March
you know
10th.
there.
March 10th,
Is it
it's right
March
here.
10th? Oh, is it right
I
there in front of
have
my face?
unmuted everyone. If anybody wants to join a conversation, feel free to.
Let's see. I'm not able to see. Is there a chat? Maybe if I stop the share? Let's see. Does anyone have any questions at all? No? See there? Oh, I do see. Thank you very much,
Thank
Melanie.
you
I appreciate
very
it. Okay.
Hey, Barry, quick question
Yes.
for you.
Sure.
So, when you are documenting, um, so when you use your documentation and you're using skin of color in your
Hmm.
documentation, okay,
Hmm.
how in detail are you using that? Like, what I mean, like, because skin of color is very general, you
Hmm.
know, so, and there's different shades. So, how do you document that to kind of get that across to the insurance?
So the
Does that make
first thing
sense?
I'll usually do, because like I was saying, even if I document it in the chart as part of like just, some EHRs have like that auto populated where you can put in the skin type. I'll also go into like the notes that they can see and I'll put the patient's actual skin type again. And then I'll also put kind of the severity of, pigmentation changes. And one thing that I think is also great to do is take photos. I don't know if a lot of people attach photos to their prior authorizations, but especially when I'm dealing with a patient, of skin of color, and especially if I know they have a really iffy insurance, attaching photos and documenting explicitly this patient has this type skin. This patient's been dealing with these results as a direct result of that skin type and the inflammation from that condition. That tends to really help things. Does that make sense? Does that answer your question?
Yeah, that helps a lot.
Yeah. Oh, thank you, Dr. Oishiku. I see that you're here. Thank you so much for watching. Does anybody else have any questions? Okay, we've got like 5 minutes left. Um, Kristen, I guess at this point, if nobody has any questions, do we?
Yeah, we can absolutely all continue on to our day. So that is no problem. But if you do have any questions, feel free to just reach out. And as Barry mentioned, he's gonna be presenting this on March 10th as well. So if you know anyone who might be interested in this topic, or if you think of any questions that are burning and you want to have that live conversation, please do join us.
Oh, yes. And I also wanted to just wrap up and say that I did do an article on HS that is on the BCoD blog. Please check that out if you have any questions about some of the information that I talked about today. That I also have a lot of other committee members and BCs that have posted some really amazing blogs on our website. So please check those out. And then also, if you check out my LinkedIn, there's some information there as far as these types of articles. I have a podcast that I just recently had that talked about kind of clinical advocacy for patients of color or just patients in general, just some helpful tips for BCs. All of that is there, so please go and check that out. All right. Well, thank you everybody so much for being here. Like I said, I really appreciate all of you taking the time to come out and watch my webinar. And I will talk to you all soon and have a great day.